gonna record it. Okay, go ahead.
Okay, ready?
Yes.
Okay, great. So this was a patient with just some incidental findings that I guess if you didn't know the history, it'd be hard to put everything together. It was a patient in her 50s. I will tell the history and just kind of go over the findings first. So scrolling down initially, both of her adrenal glands are enlarged, kind of with nodular thickening, and immediately adjacent and contiguous with them, there are bilateral large retroperitoneal masses which contain macroscopic fat. Incidentally, she had a horseshoe kidney. And as you scroll more inferiorly, there are similar appearing lesions in the retroperitoneum that appear to be satellite, but not contiguous with the dominant lesions. And interestingly, in the pelvis, both of her ovaries are markedly enlarged and heterogeneously enhancing, kind of make you think that she has bilateral ovarian lesions. The reason she was actually in the hospital is she had a longstanding history of diverticulitis with a chronic leak with this collection in her pelvic cul-de-sac. And so she was admitted with colorectal surgery for management of that. If I told you your history, you may start to think about what all the findings we've gone over could be a manifestation of.
Anyone
and so,
have any guesses?
yeah.
Do we have residents?
No.
I mean, thinking like VHL or men or something.
Those are great
Something
thoughts.
genetic.
Yeah, it's a great thought.
Those adrenal glands are like massive. So that's one clue. I showed Cookie a case like this, and she brought up something. It was a male patient in my case, but when she saw the huge adrenal glands, like nodular huge adrenal glands like that, she brought something up that is the answer in this case.
Yeah, and I guess we classically think about
So
it
this
more in
is
men.
brown fat hypertrophy from, is that Theo with brown fat hypertrophy or something that causes brown fat hypertrophy, right?
No.
I don't know. No.
So in my
Okay.
case, Cookie told me when she saw the huge adrenal glands, she asked me if there was a scrotal ultrasound. And in my patient, there was a scrotal ultrasound with bilateral testicular masses that were TART tumors, testicular adrenal rest tumors. And so anyway, Krishna, I'll let you take back over.
Yeah, no, that's kind of right along those lines. So going into the chart, we figured out that, I guess I was doing this when I was moonlighting, I figured out she had a history of 21 alpha hydroxylase deficiency. So she has congenital adrenal hyperplasia. And kind of reading through the notes, it sounds like she'd been poorly controlled for a long period of time. So classically with 21 alpha hydroxylase deficiency and CAH, those patients usually, if they're completely hormonally deficient, will present at birth. The male patients will usually have salt wasting, whereas the females, because of the elevated androgens, will have hirsutism and clitoromegaly. She actually presented later in life. Sometimes they have, partial function of the hormone. So I think her initial presentation was with during puberty with amenorrhea. And then in patients, from what I learned is that, so patients who have uncontrolled CAH, as she did, will have unopposed ACTH stimulation. And although this isn't proven, the idea is that these patients can actually develop large myelolipomas. And the thought is that the ACTH results in metaplasia in the adrenal glands, resulting in formation of, the myelolipoma, which is composed of myeloid and erythroid tumor, as well as a fat-containing lipoma component. And in her case, again, she's uncontrolled because these patients are deficient in mineralocorticoids and glucocorticoids. So she should be on longstanding, aldosterone and cortisol equivalents. And then again, going to the ovaries, if we're looking in the literature, I think we've probably all seen a case here or there of the TART tumors in the testicles with the adrenal rest tumors. But in literature, I didn't really find a lot of information about ovarian adrenal rest tumors. The cases I did find were young patients, probably who were getting their ovaries removed for whatever reason when they were in their teens. And oftentimes those ovaries were normal radiologically. So I don't think there are a lot of cases that describe the imaging appearance of these ovarian adrenal rest tumors. I think certainly in our case, there just look like there's solid bilateral ovarian masses. I don't think you could really, without history, come up with an accurate diagnosis. And so she actually went on, colorectal surgery went to take her to do to remove her colon and try and bypass her to give her an ostomy. And they wanted a gynecology to take her ovaries out to increase her visualization, and also because she's had these masses for years now. And initially the pathologist had called them sertoli Leydig cell tumors. But then upon review here with the Emory pathologist, looking at the clinical history, they thought that these are more likely to be adrenal rest tumors in the ovaries themselves. From what I was reading about, I think one differentiation they can use is the classic Sertoli Leydig cell tumors have this intracytoplasmic like protein. I think it's like a Reinke crystal. It's like a crystalloid structure, and it's composed of like 3 beta steroid hydroxydeogenase, and that helps convert or produce testosterone in these tumors. Whereas these ovarian adrenal rest tumors lack those crystals, which help them kind of further make the diagnosis.
Great case. Oh my goodness.
Is that amazing?
Yeah. Wow. I've never seen this.
And the one I actually have now fetched my case, my companion case. I'm going to show that. But in my case, it was just adrenal hyperplasia. So I think this one also had the myelolipomas, but I think classically, one of the classic findings is if you have the adrenal hyperplasia, like how big those adrenal glands were. So it was an awesome case, but I couldn't believe.
Yeah.
And then, like, then in a male, look for the testicular rests, and I guess in a female, look for ovarian rests.
Cool.
Okay, I'm going to. So I just wanted to show this companion case. So this was, I don't know why it's flipping around, but this was a case where I also we had less dramatic, but adrenal, like big adrenal glands, big adrenal hyperplasia. And in this case, this was a male patient, and then this was what their testicles looked like. So they had bilateral testicular masses on both sides, pretty hypervascular, and these were actually testicular rest tumors. So bilateral testicular masses are, you think about things like lymphoma, atypical things like TB and sarcoid. But if you have a combination of bilateral testicular masses as well as adrenal hyperplasia, think about CAH and these enzyme deficiencies. And these are called TART, T-A-R-T, testicular adrenal rest tumors.
I had a question earlier about the fat hypertrophy. I'm sorry, what was that from again? That we see with ACH?
You mean in Krishna's case, the myelolipomas?
Yes.
So he found in the literature that there's a theory that the ACTH can induce myeloma.
Like, yeah, like I think from what I found, and it's interesting, like I found like almost like 8 case reports of just giant bilateral myelolipomas in patients with CAH. I don't think anyone's ever written like a big consensus paper on this, but if you look it up on the internet, you'll find like 7 or 8 case reports. And some of them will talk about how, I guess the theory is that in patients who are poorly controlled with CAH have elevated ACTH, and over time, that ACTH elevation can result in metaplasia and result in formation of these myelolipomas in the adrenal glands. The only thing that didn't make sense is they even say this in their papers is that when they go on to resect these tumors, they can't really find like ACTH receptor expression, but maybe somehow the ACTH is resulting in these tumors from being formed again in poorly controlled patients.
Gotcha. So I guess are these cases like earlier stage version of what could become other things?
Yes. Yeah, but mine had the more dramatic testicular tumors that they initially thought were like, malignancy, and turned out to be adrenal rests.
Yeah, I think with the case that I showed, the reason it's so dramatic is just for whatever reason, I guess she doesn't have it severe enough to where she's like salt wasting and, or has like in Cushing's, like an Addisonian crisis without cortisol, but she just hasn't been taking any meds for, I don't know, 30, 40 years now. So it's just been long-standing.
Very cool.
This is a really great case of this condition.
Residents, any thoughts? Or fellows?
Or fellows, yeah. There's pericardial effusion. The pericardium is also probably a little thickened. There's maybe some interstitial thickening in the lung bases. And then in the abdomen and pelvis, there's several findings. There's kind of this retroperitoneal thickening around the aorta, retroperitoneum, and of course the kidneys. Bilateral kidneys are also abnormal. What? I heard someone say something.
Is it Erdheim Chester?
Yes, so this is a case of Erdheim Chester. So for the residents who are on, I'm going to share a Radiopedia page with you. So this is Erdheim Chester is a type of kind of histiocytosis. It's multi-system, so head to toes. It affects all systems. In the chest and abdomen, we see all the classic findings that we saw on this case. So in the lungs, you get pericardial effusion, pericarditis, or kind of pericardial thickening. In the abdomen and pelvis, we see these, they call them hairy kidney sign, kind of what we saw, the bilateral perinephric infiltration. And then there's like periaortic soft tissues like we saw. And then, yeah. And then there's like stuff in the head and neck too. But
Very cool. How do you treat it?
this patient was treated with a medication. I can tell you what it is, but I don't know what it is. I don't know like the mechanism behind
Okay.
it.
Nice.
And another interesting fact is like because they have this peri-aortic.
Claridipine.
Oh,
Sorry, go ahead.
No, because like this kind of perinephric stranding can also occur with this IgG infiltrative disease. The difference between the Erdheim Chester and IgG is like IgG will not have any skeletal involvements, but Erdheim Chester, like skeletal involvement is one of the predominant in manifestation.
Of Erdheim Chester?
Yeah.
Oh, okay, actually,
Skeletal is predominant.
as you mentioned that, I'm going to share the skeletal stuff because then it'll help us remember. So the patient does have skeletal findings. So this is an MR abdomen, and the marrow signal is abnormal. It's too dark. It's too dark, too hypointense. And then the post-contrast images there's also the kind of this diffuse heterogeneous enhancement, and then there's restricted diffusion. So
Wait, what happened to her kidney stuff?
oh, she got treated.
Oh, wow. It's like completely
it did
disappeared.
really
That's
well, like
amazing.
super, very, very good response. And then her marrow, like there's a diffusion restriction. So that now they're working her up for Erdheim Chester can involve the skeletal structures, like was that Anu said? And,
Yeah.
and so these are some of the findings.
Awesome. IgG4 also, because it's fibrotic, can cause hydro. So like sometimes when it's encasing the kidneys, it's more obstructive. Okay.
Okay, so this is a patient who was transferred from an outside hospital, and his weight is about 550 pounds, so he cannot get CT or MRI. And he was admitted outside for 2 weeks, 14 days, and nobody knew what was going on with him. He came to us, he was bacteremic, he was like in delirium, he was really sick.
Sorry,
So
you said the patient was 550 pounds?
Yeah, over 550 pounds. So he exceeds the weight limit for CT and MR.
What's the weight limit for MR?
I think it's around 500, I think. Some 400, some 500. It might be because of his circumference as well. Not only the weight.
It usually depends on the scanner, like the manufacturer, it's usually around 450.
Yeah. I think our wide bore is 450 maximum weight capacity. But I don't know what the I mean, it's larger bore, so, but I don't know if we can accommodate this patient.
Yeah. So the sonographer, so there was a liver lesion, there were at least 2 liver lesions, but I wanted to show the residents what the sonographer measured as a gallbladder. And I want to see what they think about this gallbladder measurements. She's measuring the wall thickness, she's measuring a lumen, so this is the left hepatic lobe just for anatomic orientation. And this is a scene clip. So we see here segment 2 branch of the left portal vein, and then segment 3 branch. So what is the location of this? She said the gallbladder is in a weird location, and that's everything she told me. So what do you think of this?
It's too medial, like too midline.
I mean, the
Exactly.
pancreas is right there, right? I mean, the pancreas is not the echogenic stuff.
Exactly. So this is
Lateral.
actually pancreas, and this is like a collection around the pancreas. It's not the gallbladder. So we weren't sure if he had a malignancy with metastatic liver disease, or if he had hemorrhagic pancreatitis with liver abscesses. So what we did is actually we gave contrast. And you see here that the center is not enhancing at all. There's rim enhancement. And then going on to the
Sorry, can
delayed
you
phase.
like zoom out a little bit, or make the yeah, the
Sure.
perfect. Thank you.
Yeah. So on the delayed phase after washout of contrast, the rim does not wash out. So this is an inflammatory process. It's not a metastatic, because metastases usually, see how the rim is still hyper-enhancing. Mets usually washes in, then washes out very quickly. So we call these, we call this hemorrhagic or complex pancreatitis with liver abscesses, and he's being treated for this now. I don't have
Wow.
a
You
long-term
made that
follow-up.
diagnosis on.
That's
I felt
awesome.
it was nice because we were able to help him, and we were very limited because we didn't have the option of CT or MRI. So that shows the potential of contrast ultrasound in such patients.
That's amazing. I just realized I've never really seen pancreatitis, like fluid collections on ultrasound, because we just go straight to CT, but that was beautiful.
Yeah, it's also important to always review what the sonographer, I mean, we have a lot, they are really, really good. They probably scan a lot more patients than us, but we have the medical knowledge and background to know that this is anatomically, it doesn't fit here. This should be pancreas. This is not gallbladder.
Great job.
Did you do a contrast enhanced ultrasound of that pancreatic pseudocyst?
There was no enhancement in it. I just took a quick
Oh,
look when
gotcha.
I was scanning the liver, but there was no enhancement in it. Yeah.
Yeah, you could even see if there was like necrosis of the pancreas with the contrast enhanced ultrasound.
No, actually, we did not look at the pancreas specifically. Good point, though. Yeah.
Okay, so focus on this area of the pancreas, like kind of in the groove area. This was a few years before the scans I'm going to show you. So a few years before, the patient was getting CTAs to follow up some vascular stuff, and there was this small lesion here. Maybe it has like a little bit of calcification in it. Okay, then a couple of years went by, and it became like this. It's larger, still heterogeneous, kind of like, you know, this is the pancreas, this is the duodenum, there's the lesion. Any thoughts about what it could be? I'll show you an MRI. So we were thinking about like things that affect the pancreaticoduodenal groove, like could this be a GIST tumor of the duodenum? Could it be a paraganglioma, but it's not that avidly enhancing? Is it an actual pancreatic mass, like a SPEN tumor, neuroendocrine tumor? And then this.
Was it like groove pancreatitis or focal IgG for pancreatitis?
That's a great thought. So you could think about groove pancreatitis. Usually groove pancreatitis, you get sheet-like like hypoenhancing fibrosis in the groove with cystic spaces and thickening of the duodenum. So this looked more mass-like than a groove pancreatitis, which is more sheet-like, but that, and then usually you see other findings of chronic pancreatitis in groove pancreatitis, but great thought. Focal IgG4 always in the differential for a focal pancreatic mass. I'm going to also show you now the MRI. So this was the MRI, and this is the lesion. It still looks like a rounded lesion in the groove, and it did demonstrate internal enhancement. So this was resected. There was a Whipple. They did a Whipple, and this turned out to be malignant degeneration of an IPMN with the pancreaticobiliary type and invasive adenocarcinoma with extensive high-grade dysplasia. So I just thought this was interesting. We always think about, you know, IPMNs, like we see them all the time, like those tiny little ones. This one, we saw the natural growth where it went, you know, from this small little guy here, but you can imagine maybe these are all like papillary fronds in here to a larger mass. And then I think in retrospect, like looking at it, it does look like maybe this is a fluid-filled thing with like papillary component to it. So anyway, this was just an actual, the rare malignant degeneration of an IPMN.
Patient. So we were just following this patient up. Patient that had a prior history of diverticulitis and had persistent pain. And there's still like things, but as I was looking through this, I'm going to show you something else. I'm like, what is this thing? In the right upper quadrant. So if you look closer, it communicates with the duodenum right there. There's the lumen of the duodenum and then that communication. And I'm showing this because this is like the biggest duodenal diverticulum I've ever seen. And I'm showing this case to share that, the duodenal diverticulums can get really big like this. It threw me off. And then after like looking at priors and then, looking at this a little bit more closer, it's just like a diverticulum, like only a diverticulum, but kind of threw me off for a second.
Very nice. The edges are kind of funny too, like
It's funny looking, right? Because it looked right, very like.
Can you go on the axial? I just find sometimes with diverticula, the clue is like you see at fluid level or you see like mottled gas in it. But yeah, I guess this one is just more air.
And then there's your duodenum here, and then there's the communication. It's a pretty wide mouth.
Okay. So I don't think this is an eye test, but what do you guys think about this mass? Oops.
They all look the same, don't they?
Oh, this entity?
Yeah.
Yeah. Well, okay. So I was thinking of what you're thinking of. So what were you thinking of?
Aggressive angiomyxoma?
Yes, exactly. So I was like, oh my God, this is classic aggressive angiomyxoma, T2 bright, like dumbbell lesion that loves like this ischioanal fossa perineal space. And then I was like, that's interesting because it's usually female patients. And according to Radiopedia, it's like 90% female. So it could be male. You can see this is a male. There's a prostate here. But then my fellow told me, no, actually the biopsy came back cellular angiofibroma. So I don't think, and I just want to tell you guys a few things about cellular angiofibroma because I didn't know about it. So I read an article about it. But I don't think, radiologically, we're going to really be able to tell the difference between that and aggressive angiomyxoma. But just so you know, there's something else called a cellular angiofibroma. It's equally seen in males and females. So unlike the aggressive angiomyxoma, it can be seen in males as well. In males, it can even involve the scrotum. So it can be in the inguinal canal and the scrotum, as well as in this perianal ischioanal fossa area. It's benign, just like an aggressive angiomyxoma, but it has a much less rate of recurrence. And it actually has less infiltrative borders. It's actually pretty well circumscribed, and they can usually just shell it out. So it has a much lower rate of local recurrence, which is usually the problem with the angiomyxomas. So anyway, just learned about a new entity here. They both tend to be like these dumbbell-shaped things, really T2 bright with these bands. And then also, they have sort of like medium-sized blood vessels in them. And on pathology, they tend to be bland spindle cells with medium-sized blood vessels. So just a cool benign lesion. In this case, they wanted us to tell them the relationship to the sphincters. And so we basically were telling them, it's sort of extra sphincteric, pushing, having mass effect on everything, but it wasn't invading. It didn't definitely invade the sphincters here.
But so this is an ant mini for the residents. So, so what's this here? Do you know what's the artifact that we're seeing?
Comet tailing.
Comet tail, yeah. So what is causing this artifact? Usually two highly reflective surfaces right next to each other. So if we see this in the gallbladder, what will you call?
Sorry, could you say that again?
So if we see this in the gallbladder, what will be your diagnosis? This was in the gallbladder wall.
Emphysematous gallbladder?
So this is not because emphysematous gallbladder would be air, so it will cause dirty shadowing. This is, if it is seen in the gallbladder wall, it's adenomyomatosis, but this is actually in the liver. And this happens in the liver from biliary hamartomas because they are very, very tiny cystic spaces. So the echo reflects between the two walls of the tiny, tiny cystic space. So these are classic for biliary hamartomas. So if you see this in a gallbladder wall, it's going to be a gallbladder adenomyomatosis. If you see this in the liver parenchyma, it's diagnostic of a biliary hamartoma. They are classic. Both of them are classic. There's no differential. That's it.
Malak, can I ask you something?
Mhm.
So if I see that in the gallbladder wall, but without thickening of the wall, it could just be cholesterolysis, right? Like it doesn't.
It could be, yeah, cholesterol deposits in Akitansky, whatever the name is, the sinuses. But usually they have association. So we usually call adenomyomatosis when we see this in the gallbladder wall. At least Bill Middleton does.
so-
I'm just following his steps.
Yeah. So, but I was talking to my pathologist because I was making a gallbladder lecture for AARP, and they were saying to truly have adenomyomatosis, like the word is adenomyomatosis, which means you have glandular proliferation. That's why on MR you can see those big cystic spaces, and then you have muscular hypertrophy. So, like if you look at on a PAT slide, it's actually like the wall is quite thick, because you have like these branching crevasses in the mucosa, you have muscular hypertrophy, and then deep in the muscle, you have all these glands, which is why it looks so tissue, right? So they said for pathologically to call it adenomyomatosis, you have to see that thickening of the wall. Like it's a much more extensive process than just cholesterolysis, which they see all the time.
Oh, interesting. Nice. So now you read these just as cholesterolosis?
Yeah, I just say like,
Oh, nice.
yeah. Because, and if it's more extensive, that's when you get like strawberry gallbladder, or if it's more of a clump, that's when you get a cholesterol polyp. But it's not actually, if you just see like a little bit of cholesterol on the wall without thickening, it's probably not true adenomyomatosis.
Yeah, nice. That's great. Thank you.
You see only the patients like without identifiers, right?
Yes.
Okay, so this was a 29-year-old male who presented with like painful like perineal swelling, and this is his T2 weighted image. I will bring up the post contrast and other sequences later. On axial, so this is the mass. And the post contrast.
This looks a lot more gnarly than mine. I'm wondering if it's like a squamous cell carcinoma within a condyloma.
Yeah, that's a good differential. This was an I'll show you the sagittal. It was impressive. So this was an anal alveolar rhabdomyosarcoma. So
Wow.
yeah, like I think the clue was maybe the T2 was better. So it was involving the anal canal, like the external anal sphincter. If you see here, I can zoom it in. So it's involving the left side puborectalis, the external anal sphincter muscle, and the predominant mass was like beyond the anal canal here. So it's like has a soft tissue component and all, like because it was a very aggressive growing tumor, it had a lot of cystic necrosis. So I think from imaging, the clinician's perspective is like they want us to mention the involvement of the external anal sphincter, because the management differs based on management, and the diagnosis differs based on whether it's involving the anal canal or not. And they usually treat it with radiation and chemotherapy primarily, just like a squamous cell carcinoma, they kind of get treated, but like this was a path-proven alveolar rhabdomyosarcoma of the anal canal.
Wow. Is invading is it the urethra and the spongiosum? Corporal spongiosum.
Yeah.
Yeah.
In the proximal portions, yes. It was a very aggressive tumor. He's only not 29, poor guy.
And you can see for the residents, like what a different look it has than that one that I showed. Mine was like very well circumscribed, really T2 bright, kind of bland looking. This looks like much more aggressive.
Mm-hmm. Yeah. I will show the other one. So this was, I'm just going to scroll through, and any thoughts are welcome. So this is more like a primary pancreatic pathology.
There's a lesion in the body with the abrupt cutoff sign.
Yeah, exactly. I will show you the post contrast. And see like the dilated ducts in the body and tail of the pancreas, and then there's an abrupt cutoff in the body. And then this is the rest of the head of the pancreas here. And you can see like the duct is kind of distorted in this region. This was an example for like an isodense like pancreatic adenocarcinoma. They don't necessarily present like a mass, but it can just cause only the the abrupt duct cutoff sign is one of the early signs which people can pick up rather than like waiting for the mass to present. So just wanted to show like how it's important to pick this up earlier on.
Anu, can you show
a couple-
the pre or the arterial phase? Because I find
Sure.
sometimes I can see it like the edges better on that.
Mm-hmm.
And with the abrupt cutoff sign, it's not necessarily the caliber dilatation, like upstream, it just has to be a change. So the upstream caliber could be like minimal or big, it doesn't matter. It just has to be a change in the transition. And over like close to 50% turn out to be pancreatic cancer, and the other 50 is usually from pancreatitis. So if you see that, it has to be worked up. It has to be worked up, ERCP, you can't let it go.
Yeah, it's like pancreatic adeno until proven otherwise. But I like this, like see here now you can see the really bright normal head of the pancreas. And then if you line that up, like, you know, you put that next to where the abrupt cutoff is, you'll see that the mass is like that dark thing. It's actually even a little bit further over, like it includes further over than where your arrow is, right?
Mm-hmm. Yeah.
Yeah, you're just showing the edge of it, yeah.
Mm-hmm.
Do you have the diffusion?
Yes.
And I want to see arterial too.
This is the diffusion.
Go further up.
Um,
Right, it's up, yeah, there.
Yeah, right there, yeah.
Mhm. And arterial.
Harder to see, but if you line that up with the pre, you'll see the edges.
Mm-hmm.
Cool.
I love the pre's for the pancreas.
Mm-hmm. And this is my other case. So this patient, she was 44 something. Okay, maybe I should move this here. Okay. She was 44, but she had like an outside CT that was done for some abdominal pain that was done without contrast. And they called a lesion in the liver. And apparently insurance denied her CT or MR with contrast. I don't know for what reasons they will deny a CT. So she had only one option left, that was getting an ultrasound with contrast. So I will just show some images. So this is what our techs found. They found a very ill-defined isoechoic lesion. Any thoughts?
I mean, it's not typical of hemange. It's, I would guess, adenoma or FNH if a young
Mhm.
female.
Yeah, that's what we thought. And like she had some more images with the better grayscale. They found like a more defined, but like still isoechoic lesion. So we did the let me- so the contrast was done. So this was the first injection, the early phase. And this was the around the lesion where we found it. And you can see this early announcement. And I will show you the subsequent one. Then we can, and then this is the second cine. And the third cine. And the fourth.
Nice. So it's a hemange.
Yeah, exactly.
There is
It
a
was-
proportion of isoechoic hemanges. Yeah.
Yeah, it was like the CT, the grayscale was not classic, but like the ultrasound. This is the first time I'm seeing the classic appearance of a hemangioma with contrast, because we usually do cross-sectional. I felt it was really nice to see
On
this.
the grayscale on the right, are we also seeing increase through transmission? Like right
Kind
there?
of, but it's like, I think because of it's artifactual too, like we are seeing a band of hyperechogenicity around this region. I think when she has a breath, like it becomes ISO if we keep noticing here, it's kind of iso here at this point. I think it's part of it is like a band of artifact around that region.
But I mean, posterior to it, I see a band, like a bright band.
This one
No, the posterior acoustic enhancement, like
here.
right there,
Here.
behind it. Yeah. So isn't that supposed to be for hemange too? Because they're fluid filled.
True, but like I don't think we saw that on the initial like images here.
Oh yeah, it's faint.
Yeah.
Yeah, maybe there is a little bit. Yeah.
Yeah, but hard to. So wait, and you said, oh, she couldn't get MRI. Yeah.
Yeah, the insurance denied. I
Oh.
don't know like why they would deny, but like this was our only option. We were like skeptical. We was like, we'll try our best, but then it was like awesome. Like it was beautiful diagnostic one.
Yeah, it looks awesome. Just for because we don't do contrast enhanced ultrasound, what would FNH look like on contrast enhanced ultrasound? I guess like gets really bright and then ISO.
Yeah, but sometimes you can catch the stellate central enhancement actually also.
Oh, the scar.
That's like the characteristic one is the stellate central, very, very early. Like you have to slow down the arterial phase and you'll see it filling in centrally to peripherally.
Cool.
This is a patient with multiple pancreatic cystic lesions. So there's a big one here, or bigger, not too big, but a few there, a few there. Got an EUS prior and it was negative. So the patient got follow-up MR. And then this is a follow-up MR.
Mass in the distal pancreas, body and tail region.
Yes. So here's your pancreatic duct cutoff sign right here. See, there's a dilated duct, and then there's this blurry evil gray here.
Mhm.
And then the upstream duct is, smaller in caliber. And then here is your right there.
Nice. You can see it nicely.
And then here, yeah. And then here is, so this is the pancreatic cystic lesion, but this lesion was not cystic on T2. It had that evil cray. And then the diffusions here. So that's why these IPMNs need follow-up.
Yeah, they say it's like a field defect, right? So sometimes it's not even in the IPMN, like the whole gland is at risk. So sometimes you even have like a de novo adeno in a gland that has multiple IPMNs. Okay. This one I don't have a final answer to, but I'm curious what you guys think about this. So tell me what you think about the bile ducts. And also the kidneys have a finding. And I'll show you, this is the MRCP. What do you guys think? Here, I'll show you the venous. So we thought there was some like fusiform cystic dilations of the biliary tree. Can you guys hear me?
Yeah.
Yes, we can hear you.
Yeah.
Okay.
Just thinking.
Very amazed.
Just thinking.
Okay, so anyway, I don't have an answer here, but I was wondering if this was some like on the spectrum of Caroli's disease, because they also have polycystic kidney disease. This polycystic kidney in this patient is not classic for the autosomal dominant polycystic kidney, where usually the kidneys are massive and have large cysts, but she does have stage 5 renal failure from this polycystic kidney disease. So just wondering if you guys buy that, if you think it could be like, because Caroli's doesn't have to be diffuse, it can be segmental. Otherwise, I had no explanation. I didn't really think it looked like PSC, primary sclerosing cholangitis, because it was more like saccular kind of dilations. So we started going down the choledochal cyst pathway, and then along with the renal cystic disease, I thought about Caroli's. What do you guys think?
I agree that it's not typical for PSC, but we don't see any central dots. Could it be like two separate things? Could it be like bilegs from an episode of biliary ischemia or cholangitis? I mean, Carol
Yeah,
is a
maybe.
thought,
She
but
has no
it's
history.
typical. Not on lithium.
Nope.
Mm.
And I mean, it's like very much on the right side only. I don't see any left side. It's
Yeah,
Caroli's
but
a diffuse process, or
if you look it up, Caroli's can be even segmental or even or lobar. It doesn't have to be diffuse.
got it.
Okay, well, I have no proof. I'm hoping she gets a liver biopsy, but anyway, that was what I thought. Oh, and then Kedar is agreeing with me. And I didn't give Kedar credit before, but he's gotten Erdheim Chester and angiomyxoma, and then he thinks could be Caroli's as well.
Fantastic. Okay, pelvic pain. My favorite studies. Gotta have one every session.
I know. I was like, Nelly, is this the same patient over and over again?
No, it's not the same patient.
Deep infiltrating endometriosis with a
Where?
mushroom cap. I see two
good.
mushroom caps. Like I see a mushroom
Okay.
cap and a fortune cookie sign.
Yes. So here is this thickening here. So let's go back to the uterus. So here's the uterus, right? And there's like it's like tethered and puckered, and the wall is thickened here. So there's a very long segment, deep infiltrating endometriosis right there anteriorly. So this patient is definitely going to need colorectal surgery with the gynecologist to do a segmental resection of the disease sigmoid upper rectum. What else? Where else?
Junctional zone.
Junctional
Oh,
zone.
Nelly, you have shown this case because it's the anterior uterus, like the bottom of the uterus between the bladder and the uterus.
Yes.
Right?
No, this is a different case.
Okay. Well, your other patient had that too.
Yes, the other patient did have that, and this one has T66 spaces here. The other patient didn't. So there is additional deposit anteriorly in the fundus and the serosa. There's no bladder invasion, but there's definitely a pretty significant deep infiltrating plaque anteriorly. And then let me see here. There's bilateral little endometriomas. Those are best seen on pre-T1s. Right there, you see the hyperintense T1 hyperintense signal in both bilateral and nexa. So this is so they're staging for DI. Oh, patient also maybe also has a septate. There's a staging for
one for the residents. We see two endometrial cavities, but the outer fundal contour is smooth, so it's not going to be a bicornuate.
So the staging is really laparoscopic intraoperative, and if it's greater than 3 centimeters intraoperatively, then they call it stage 4. So this is definitely stage 4. You have to have one every session.
So residents, you see any finding?
There's asymmetric enhancement of the kidneys.
Yes. And what do you think is causing that asymmetric enhancement? I can show you the coronal if you want.
Sure.
It's pretty geographic, right?
Right.
So what do you think? Or what are even some possibilities?
This could be like an infarct to the kidney with retained perfusion to the, what is that, the lower pole? I feel
Good. So we were thinking infarct, you could think about pyelo, but that's usually more of a striated nephrogram, usually not as like demarcated, preserved part from maybe an accessory vessel. And then does anyone see any other finding?
There's like thickening around the ostium of the left renal artery.
Okay, thickening here. Good. I'm going to now show you, well, I'll show you the CTA was done the next day, but something that was not seen here, but in retrospect, I just want to raise awareness about this. There's a faint flap here.
Oh.
And so actually, I
Yeah,
found this
and
really
it goes down
scary.
the SMA. Jeez Louise.
Yeah, I found this really scary that like on a portal venous phase, how easy it could be to miss a dissection. But like Nelly did, immediately she went to the vessel. Okay, the vessel looks weird. So then they're like, okay, let's do a CTA. So then they did a CTA. And there was a dissection all the way from the thoracic aorta down that you can see much better on this arterial phase. We can see that the left kidney, there's an arrow sign there, but the left kidney is being fed by the false lumen, but that there's like literally basically an occlusion of the left kidney there. So my colleague Amir, who's also does chest and is really good at vascular stuff, was saying, the reason this vessel got occluded is not because it's being fed from the false lumen, it's because the dissection probably extended into the renal artery, and that predisposes it to getting thrombosed and obstructed. So because the dissection flap extended into there, this kidney got obstructed. And then the reason that the lower pole was preserved was actually there was an accessory renal artery, even though it came off higher up, it was feeding this lower pole here. So that was able to preserve the lower pole because there's no dissection flap going into the accessory artery. So if you have an infarct, always look at the artery, and then I guess just look very carefully at the aorta because you can see it in retrospect now here. So just a good cautionary tale.
Thank you.
Yep.
How many residents are at the Trinity program?
There's only 2 of us today, but in total right now there's 16.
Oh, wow.
Cool.
So anything that you notice, residents?
Can you zoom out a little bit? We just see the zoomed in
Zoom out?
pelvis. Yeah, just a little
I'm
bit.
making
Yeah.
it easier
Oh,
by zooming in.
I mean, right off the bat, there's anasarca, there's ascites.
Okay, anything asymmetric?
The external iliac vein on the left?
Yes, one is ossified, one is not ossified. So which one do you think is normal? Which one is abnormal based on the phase of this? So it's kind of late arterial
Right
early.
one is abnormal.
Which one?
The right?
Right is abnormal, yes.
They're like
So,
an AVM.
so this is degraded by sleep artifacts, but we did an ultrasound immediately after, and this is correct. This is an AV fistula actually, and you see the tissue vibration and the communication here. Yeah, great.
Very nice. Did you guys say AVF or AVM?
AV.
AVF. I think it was post-procedural AV fistula.
Yeah. It's an
Malformation.
AVF, but I just want to make
Yes.
sure that the residents that we distinguish AVF from AVM, which
Yep.
would be like more of a congenital thing. Cool.
So this was a routine oncology follow-up patient, and we have this like pedunculated fat density lesion, perianal lesion, which has been stable for like over a year. So is it like a pedunculated lipoma, or is it like a very hypertrophied skin tag, or is there another entity that I'm not aware of? I don't know. And we have a very similar case that we saw with ultrasound, like maybe 2 weeks before this, like a totally different patient that looks exactly the same. So I wasn't sure if any of you have seen anything like this before.
negative, but looks benign.
Yeah, that's what we thought. It looks benign. We didn't know what it was. I just remembered with all these angiomyxomas, oh, this looks a little bit similar, but it's completely fat density. Okay.
I
Cool.
like the skin tag idea.
But it's a little bit further away from the anus.
No, I mean, just from the skin.
Yeah, just from the skin, not related to like I was thinking maybe it's like a hemorrhoid, because sometimes like a skin tag from hemorrhoid could become hypertrophy, but this is too far. So it could just be from the skin itself, you mean?
Yeah.
Yeah. Yeah. Okay. Reassuring to know that nobody has seen it before.
Okay, awesome. Thanks, guys. See you later.
Thank you.
Thanks all.
you.